Okay, so now we're going to take a look at the gallbladder. Specifically, just for right now, we're going to look at the stones that are common in the gallbladder and the infections. So to get a quick understanding, let's just take a look at a picture of the gallbladder here. So first thing, you can have stones in two locations. Firstly, you can have stones in the gallbladder itself. This is called cholecystitis. And then you can have stones in the duct. And this is called choledecholithiasis. Secondly, we can also have infections, and depending on what the infection is, they have different names as well. The first place you can have an infection is going to be in the gallbladder. And when you have an infection in the gallbladder, that is called cholecystitis. And when you have an infection anywhere in the duct, we call that cholangitis. And so today we're going to just take a look at all four of these conditions. First the stones and then the infection. So first continue with cholelethiasis. So we have cholelethiasis, and its counterpart is going to be choledecholithiasis. Firstly, there's going to be two types of stones that are the most common. The first one is going to be the cholesterol stone, and the second is going to be the pigmented stone. Cholesterol stone forms either because you're forming too much cholesterol, or you're not secreting it fast enough. So and this helps you figure out the etiology. So what can cause increased secretion of cholesterol? This is going to be caused by old age. Females tend to have this more often, especially when they're pregnant, and obesity. Not only obesity, but quite paradoxically, rapid weight loss is also there. Now, along with increased secretion, we can also have decreased emptying. And so when the gallbladder is not being emptied quick enough, that leads to supersaturation of cholesterol and formation of stone. Now, what can cause decreased emptying? Firstly, it's going to be fasting state. And so pretty much people on total parenteral nutrition, where the gallbladder is not stimulated to contract. And then after that, we're going to have pregnancy again, and spinal cord injury. That can decrease the neurological signal to the gallbladder to contract as well. Now, with pigmented, there's two types of pigments depending on the color. First, we have black, and then we have brown. Black signifies hemolysis, and so this is common in patients with sickle cell anemia and thalessemia, whereas brown, it just signifies some sort of infection that is present there. So continuing on, what are some of the clinical signs? So now let's focus on the clinical aspect. Well, cholecystitis is most often asymptomatic. Sometimes just an incidental finding. And again, if you look at cholecystitis, you just have a few stones in the gallbladder, and they're not going to cause any problem until one of these gallbladders blocks the neck right here. And when it blocks the neck, you get a typical type of pain. Here it is. So you can see in this picture, the pain is going to be located in the epigastrium to the left flank. So the pain is going to be, let's write this out. So it's going to be epigastric, say right upper quadrant, and it radiates to the, back here and to the scapula. So it radiates to the scapular area, we can say. And what patients will also notice is it's associated with eating. And this is because when you eat, this leads to contraction of the gallbladder, and that's when you're going to get the stone moving up here during the contraction of the gallbladder. So that's why it's associated with eating. However, it only lasts about 2 hours. If it's lasting more than that, then you probably want to think more of cholecystitis in that instance. Now, what kind of investigation would you do? Let's write that in here. So the next would be your the different investigations you'd want to do. You'd want to do an ultrasound. That is your first choice method. Do I have a picture here? Yeah. So upon ultrasound, see picture here. You can actually visualize the stone. As you can see here, there's 2 stones visualized there in the gallbladder. And to see some complications that we're going to discuss in a little bit, you're going to want to do CT and MRI. Since we're we'll discuss the complications a little bit. Next is going to be, how do we treat this? If it's asymptomatic, no treatment is necessary. They'll probably have it and it will never cause them a problem. So if it's asymptomatic, then you don't treat. No treatment. However, if it becomes symptomatic, you can try giving them oral bile acids, or even trying lithotripsy. But if these aren't working, or if this is unavailable, then you just have to do a cholecystectomy, laparoscopic, and that'll take care of that. And finally, what are some of the complications? The complication that you can get is going to be, the first one is going to be gallstone ileus. And with the gallstone ileus, what happens, actually I'll show it on the picture here. So in gallstone ileus, there's a little tract that's created between the gallbladder and the duodenum, and the stone can go through into the duodenum, and then if it's greater than 2.5 millimeters, it can actually trap into the ileus and cause GIT obstruction. Otherwise, if you go back up, it can cause choledecholethiasis, and it can even cause pancreatitis. So those are the 2 main things there, and it can cause cholecystitis as well. So you have choledecholethiasis and pancreatitis if it gets down into the bile duct. Okay, so that's the cholethiasis. Now let's take a look at the choledecholethiasis. This is a stone in the bile duct. Now the most common origin of the stone is going to be from cholethiasis. So there are some primary stones which can be formed, but primarily you're going to be getting it from the cholethiasis. What kind of symptoms will they have? So clinically, what would you see in choledecholethiasis? Again, just like it can remain asymptomatic. So just like cholethiasis, it can remain asymptomatic. But again, if it gets down to the common bile duct, so if it gets down to this area, anywhere here, then you're going to, obviously it's going to cause jaundice, obstructive jaundice. And of course you're going to get the right upper quadrant pain, and all those things, just like the cholethiasis as well. What kind of investigations would you do for this? Well, remember, in the common bile duct, we have a very specific investigation that we can do. It's called the ERCP. ERCP can not only detect, but can also remove the stone. And when you're going to treatment, again, all you got to do is just get your ERCP, remove the stone, and of course you want to give them analgesics for the pain and antibiotics to prevent further infection. Okay, so that's our stones there. Now we can get into the different types of infections. And again, the infections are going to be either the gallbladder or the bile duct. So the gallbladder infection is going to be cholecystitis. And the bile duct infection is going to be cholangitis. So this is going to be infection of the gallbladder. Whereas here we're looking at infection of the bile duct. Now, what will cause infection of the I'm sorry, not saying infection, actually, sorry. Inflammation. Sorry about that. Inflammation of gallbladder. And this is going to be inflammation and infection. This does get an infection as well. So what causes inflammation of the gallbladder? Just easily, you just want to think any type of obstruction. And so, of course, the most common obstruction is going to be the gallstone that you would see. But it can also be some type of worm or parasite, such as Clonorchis sinensis. We can actually write this down. The different types of worms and parasites, it can be Clonorchis sinensis, Ascaris lumbricoides, and Fasciola hepatica. And this can cause cholecystitis, and it can also cause cholangitis. Both these worms. Now, can it happen without an obstruction? It can. This is called acalculous cholecystitis, and this is generally in patients who are bedridden and they're getting, TPN. They're getting, or they're sickle cell patients, and it's also found in diabetes mellitus patients. For cholecystitis, what do you see clinically? Well, you're going to see the same pain as cholelithiasis, except longer. So you get the same pattern of pain as cholelithiasis, except it's much longer and it's more severe. So whereas cholelithiasis lasts 2 hours, here is going to last 6 hours. And on top of that, it's an inflammation, so you're going to get a fever associated with, and this fever has no rigors. And of course, you're going to have leukocytosis, which you would see in your lab investigations. It wouldn't be, a symptom per se. But these are the kind of defining features that help you differentiate cholecystitis from cholelithiasis. Now, the other thing here, you can get a gallbladder mass, but this is generally a late finding, and this is associated with jaundice. And the jaundice is either going to be, because just jaundice, sorry. But the jaundice isn't always there, sorry, it's only going to be when it's in less than 10% of cases you actually get jaundice. Okay, what type of investigations would you run here? Well, you would do if you do CBC, of course you're going to see the leukocytosis that I mentioned earlier. You'd also want to do amylase, and this is because the pancreas can get involved, but only greater than 1,000 international units is significant. You'd want to do ultrasound to actually detect the stones that may be there. But what's also in the ultrasound, let's see, let me show you, I got a picture here. Okay, here you go. Just carry this picture out here. So here's an ultrasound. There's a few things that you're going to look for. First thing is going to be a thickened gallbladder wall that you can see that they highlighted right here in the green. That's the thick wall right there. And then there's going to be some pericholecystic fluid. And in this one in particular is the sludge. So this sludge is the bile sludge, rather than having the actual stones. So these are kind of the ultrasound things you would see. Now you'd also want to do an X-ray. Upon X-ray, of course you can see the radiopaque stones, but again, ultrasound does that pretty well. But actually what you also want to take a look at is to make sure there's no pneumonia in the lower lobe, because sometimes one complication is that it extends into the lungs and causes pneumonia. And you're going to do CT if there's any perforation or empyema. So the CT is mostly just to see, evaluate complications, not to diagnose. Okay, and finally, we can move on to cholangitis. So cholangitis, as we discussed earlier, is an infection or inflammation of the bile duct. Now, again, what can cause it? Obstruction, just like with cholecystitis. Now, this obstruction can come from a stone, so choledecholicthiasis, or it can be some type of stricture, or it can be due to pancreatitis. All of these can cause cholangitis. Now, finally, we can go on to, let's go on to clinical here. Now, clinically, what do we see? This has a very famous symptoms called Charcot's triad, and then there's also Raynaud's pentad. So what is Charcot's triad? Basically, if you have a patient who has right upper quadrant pain, fever, and jaundice, that's going to be most likely, it's going to be cholangitis. And then pentad, we just add hypotension and altered mental status. If you see this on top of it, then this means that they're going into shock. So this is a dangerous sign here. Now, what would you see on investigation? Oh, sorry, one quick thing. Okay, I'll come back to that at the end. There's one thing I forgot, but we'll come back to it. I'll just finish this up. On investigation, we have, you can do an ultrasound, and the ultrasound will generally show dilated bile ducts. And so after that, you can also do ERCP, and this is also good because not only can we see the stones, but it can actually remove the stones. And so that's the kind of a benefit there. And of course, you want to do your laboratory investigations. What are you going to find? You're going to have leukocytosis because this is an inflammation. You're going to have, of course, the bile duct is involved, and ALP will be raised for that. If the pancreas is involved, amylase can be elevated, and of course, you can have a high bilirubin as it starts to involve the liver. Finally, what kind of treatment are we looking at? And I actually forgot to do the treatment for the cholecystitis, so we can go ahead and we can do that in a little bit. So treatment would be two types. You first want to treat it acutely. And when you treat acutely, what you want to focus on is giving them IV fluids, analgesics, and antibiotics. Kind of your three that you want to do all the time. Now, while you're doing this, you also want to make sure you're monitoring hemodynamics because you don't want to. You want to catch any signs of Raynaud's pentad as early as possible. Then you want to, you want to do definitive treatments. Definitive treatment, you'd want to start 48 hours of being afebrile. And usually it's going to be related to using ERCP. Now with cholecystitis, I did forget a few things actually. Firstly, there's also a Murphy sign. Murphy sign is very important. What this means is there's increased tenderness as they're inspiring. So if you put your hand under their rib cage towards the liver, and then you ask them to inspire, and as the rib cage goes up, your fingers will tap the tip of the gallbladder, and then there'll be some tenderness, and they won't be able to finish their breath. They'll kind of stop. For some reason, I forgot the treatment protocol for cholecystitis. So once you've confirmed cholecystitis, you want to initiate with conservative treatment. And this, just like cholangitis, IV analgesics, IV fluids, analgesics, and antibiotics. You want to give them some bowel rest as much as possible, and you do that by giving them nil per oral. Finally, there's going to be you're going to want to do surgery, and this, of course, will be laparoscopic cholecystectomy. And if you start laparoscopic cholecystectomy and it's there's a high amount of infection or inflammation, then you want to just go open as well. Okay, so that is just a quick overview of cholecystitis, cholangitis, and the cholelethiasis and choledecholithiasis.